lasting experience at John while people are looking on here. Patient, she's been a patient for about 30 years, and she is 74 years old, and she has been decay-free until this cup today. And I saw her 6 months ago, and she had 17 is completely bombed out. I'll be extracting it. I have serious lesions on 32, tooth number 3. I'm going to have to redo a crown. I think one other molar. I think it was 31. And, you know, I sat down and asked her. She had plenty of saliva. Her spots, and I'm scratching my head, and she's not taking any medications, like multiple vitamins. She's healthy and fit as can be. I mean, she's a very healthy person, and has been for, you know, my entire career. And so I just kept asking her questions and talking about sugar. And nope, I put sweet and low on my Cheerios in the morning. I drink my coffee black, and I mean, we go on. And I said, well, what else do you drink? You know, what are you eating? Because you got plenty of saliva. You don't have any. Her bacterial count was low, and finally, I asked her. She says, "I said, you eat?" She goes, "Well, I do like to eat a lot of ice cream." And I really, it's a recent thing. Yeah, for the last year or so, I eat a big bowl of ice cream before I go to bed at night. And I'm like, okay. And do you put anything on it? Oh, I smother it with chocolate syrup and caramel sauce.
Oh, great.
And I said, then do you like brush your teeth before you sleep? Oh no, then I normally just crawl in bed and go to sleep. And I said to her, we found the problem.
Yeah,
right? I mean, you know, it took me probably 10 minutes of open-ended questions before we finally figured it out. And
it's all very well to look back, but one of the questions to ask in that case is, what has changed in your life in the last 12 months? What differently?
What differently?
Yeah.
But since we figured it out, otherwise, like I told her, I said, hadn't figured this out, a year from now, you'd be sitting here with 4 new large cavities, and I'd be scratching my head, you know?
Yeah, her bacteria count would be well up by that time too.
I would think so. Yep.
And it's to show that we've probably all got, well, probably definitely all got virulent bacteria in our mouths. Just a matter of them up.
Yeah. Yep.
And talking of the book, altering the balance.
Yeah, altering the balance. Her balance is out of whack, but we're going to get her back in balance. So anyway.
Are we due to start soon? Sometime?
We are.
I think. Yeah, we are good to start. So I will go ahead and just get started. We'll do some actions and take care of some housekeeping items first, and then I will let you guys take it on. So good evening, everyone. Thank you for joining us and learning about the newest science on dental caries and CAMBRA. We have some really exciting stuff for all of you tonight, but just before we jump in, I do want to take care of a few housekeeping items. Now, you all are muted on the call, so we can't hear verbally any comments or questions. If you do have questions during the presentation, please type them into the Q&A box on the right-hand side of your screen, and you may need to escape out of full screen mode to see that box. And at the end of the presentation, we will have about 15 minutes to answer some questions. If we don't get to all of them, we will be replying to those throughout the remainder of the week. And now, last but not least, the webinar will be recorded, and you will be sent a follow-up email with the link so you can view it any time. If you want to share it with colleagues, you're more than welcome to do that as well. So with that being said, I would like to go ahead and introduce Dr. Kim Kutsch, CEO and founder of Oral Biotech and the CariFree system. Dr. Kutsch has been successfully practicing dentistry for over 30 years and still practices 3 days a week here in Albany, Oregon. Has an incredible passion for what he does, and his vision to create effective CAMBRA protocols is what continues to drive him in his research to improve caries diagnosis and treatment. And Dr. Kutsch, I will let you do the honors of introducing our guest and presenter for the night as well.
Thank you, Kel, and everybody. It is my extreme and profound privilege to get to introduce our speaker tonight. Dr. John Featherstone is currently Professor of Preventive and Restorative Dental Sciences at UCSF. He's also Dean at the School of Dentistry there. He holds a PhD in chemistry from the University of Wellington, and his list of achievements and awards and recognition go on and on. Most notably, most recently, he received the Norton Ross Award from the ADA on excellence in clinical research, and Dr. Featherstone has to me personally has been an incredible friend and mentor and a huge inspiration, and has helped me tremendously as I've been trying to figure out CAMBRA and how to implement it in my practice and make it I think feasible for other practitioners to use as well. So, John, welcome, and I know that everybody's excited to hear your presentation tonight.
Thank you, Kim. So tonight, what I've put together is an update on applied bacteriology. Obviously, what's happened in the last 12 to 18 months, there are many things, and I'm a little biased towards some of the work that's come out of UCSF, and there'll be some accent on that, but I've tried to choose things to present tonight that will help you in your everyday practice now or at some point in the future. Firstly, I have to disclose I've got no personal financial interest in any company relevant to this presentation. I don't have shares in CariFree. I've been careful to avoid that, so there's no conflict of interest, neither with any healthcare company. So, but I've consulted for or have done research work for about every healthcare company, dental healthcare company that's out there. I want to give you one or two cold hard facts relevant to your dental practice for a start, which you may not know. And the view you see in front of you are huge icebergs in the Antarctic, and at the suggestion of Kim Kutsch, in fact, my significant other and I had a fabulous time in Antarctica last December, and I couldn't help but look at this and think about teeth and decay and fractures and whatever. So I want to emphasize the caries balance, which I first published in 1999, that we have the pathological factors on one side, acid-producing bacteria, fermentable carbohydrate frequency and subnormal saliva, and the protective factors on the other side, flow components, fluoride, calcium and phosphate for remineralization, and antibacterials. With this simple diagram, you can basically understand the caries problems of any of your patients. And Dr. Kutsch and I were talking about a patient just before we all came on the air, where he had solved a problem for that woman who had been caries-free for a long time, just by thinking through the caries balance, and it was a dietary issue. So that's not new. It's been around for a while. And you hopefully are either using or will be using the caries balance concept in your practice to assess the caries risk and stay in balance to survive. This view here is my oldest son on a photo shoot for a ski magazine, actually, on the side of a real mountain. In balance, surviving well. That's what we want our patients to do, and have this happen in their mouths. So, by the way, hopefully you can all hear me well. If not, just type something in the chat column, and I'll turn up the volume. I'll first share with you some information that was published recently in October 2011, and that's a validation exercise that we did here at UCSF. It's a sheer retrospective study that was done in our pre-doctoral clinics. So there were literally hundreds, if not thousands, of students involved in this. They were taught how to do caries risk assessment, and they were supervised by regular faculty, some of whom are good and some of whom are not good at this supervision. The results really are amazing and outstanding when you think of that. Based on 12,954 patients over that 6-year period, and if you look at the right-hand column, and I don't know whether I can to that, probably not, the right-hand column that says OR is odds ratio. And an odds ratio of 1 means there's no relationship, and 1 means there's a strong relationship. Restorations in the last 3 years, odds ratio 1.5. proximal enamel lesions, that's on your bite wing x-rays, huge 8.2 odds ratio, which means if you pick up those lesions, cavitated lesions in proximal surfaces, that's a very strong indication of disease activity. Doesn't you drill and fill them, everybody, all 140 of you who are in attendance according to my screen, but it doesn't mean that you need to do something with the disease. And lastly, white spot lesions on surfaces, another huge odds ratio, 2.8. And if we look at items in the risk assessment form, whichever one you use, whether it's the CariFree one or the CA one or some modification, these items are in there. Heavy plaque on the teeth, 2.6. Recreational drug use, almost 2. Deep pit dishes, frequent snacking, inadequate saliva flow, and exposed tooth roots. All of those in 13,000 patients, each of them with a high odds ratio. If we have protective factors, fluoridation in the community, that's fluoride drinking water, fluoride toothpaste use, and fluoride mouth rinse use, those odds ratios less than 1, which means a significant negative relationship, as we would expect, but proven extremely strongly in this study. And what about a follow-up? This is 2,500 patients at follow-up exam, whether or not they had cavities. And I'm going to skip to the summary slide in a minute and talk about those numbers again. But I do that, mutans streptococci, as measured by the Ivoclar dip slide method, very strongly related, and lactobacilli, very strongly related. No surprise, but very strong data out of 13,000 patients. So those with high mutans streptococci, 9% of them went on and got cavitations. Those with high lactobacilli, 90% of them went on and got cavitations. So folks, bacteria have something to do with the disease. So our caries risk assessment, 60% of those identified as high risk progressed to have new cavities within 2 years. 88% identified as extreme risk progressed to new cavities within 2 years. It's high risk plus salivary dysfunction. 26% that were identified as low risk did not progress to cavities. The assessment method is validated. The CariFree method is almost identical. It's also validated by the same study. You do need effective remineralizing and antibacterial therapy, both of those, to deal with extreme high-risk patients. So let me talk briefly about pathological factors, our carcinogenic bacteria. I think hopefully everybody on the call is aware of Streptococcus mutans being related to caries. Some of you will have heard of Strep sobrinus, others not. Lactobacillus species. I showed you some data, the latest data on thousands of patients showing relationship. There are others that are also involved. And new data published by Tanner and co-workers a year and 2 years ago, that's very, very recent data, involves, among others, bifidobacteria. Most of you have never heard of bifidobacteria. That has been around a long time. Scalia, a new one. Well, it's not new, but newly identified. And I hear watch this space is related to high caries in children, presumably adults as well. And Lima et al., Care Research 2011. This is occlusal caries in dentin. Lactobacillus species, vanilla species showing up again, actinomyces species. Will you hear that was root caries? Well, folks, it's related to coronal caries as well. And bifidobacteria. In fact, any bacteria that produce acid as a byproduct of metabolism. What does it mean? We don't have one species of bacteria. We can't have a vaccine against one species of bacteria. We have an antibacterial against one species of bacteria that's going to be our silver bullet. It ain't going to happen. You look at this recent data in the last 2 years, it just confirms what some of us have been saying for 30 to 40 years now. It's a multi-species bacterial species disease, no question about it. And we have to modify the biofilm. And talk about the ATP tester that CariFree is some of you are using, measures ATP, and all of these species that I've just talked about are ATP producers. So we have to do something about those bacteria. All high risk and extreme risk patients are continuing to get decay, just like I showed you in the previous data. Biofilm modification is necessary as part of our therapy, and if you're using biofilm modification in your practice, please start tomorrow. There's a transmissible bacterial infection, and these bacteria are passed on from child to child, adult to child, etc. Multiple species are responsible. So jump now to protective factors. And fiber, of course, is a very important protective factor, but I'm looking here for new data that's going to help you out tomorrow. And I want to come in on fluoride, calcium phosphate, and remineralization. And a very excellent paper, and a relatively recent one, almost 2 years old now, year and a half old, of Nystrom and Burkhead, who convinced of the usefulness of the 5,000 part per million fluoride toothpaste. And they compared 5,000 part per million fluoride toothpaste with over-the-counter 1450 part per million. In Europe, 1450 is very common, around the 1,000 that we have here. The huge thing is that the comparison was between 5,000 and 1450, and there was a huge difference. And they measured this in caries active adolescents. It was a 2-year clinical trial. Preventive fraction 4%, 5,000 versus 1450 part per million. That's why we're recommending the use of 5,000 part per million for every age group over 6 years, any group beyond that, adults, geriatrics, people like me, whatever. 5,000 part per million fluoride toothpaste is exactly the silver bullet, but man, it does swing that balance. And those of you who are using it and persuading your patients to use it, I get anecdotal comments all the time, man, this is like a miracle. So, moving on to a little more about fluorides. We've heard about fluoride varnish. Again, it's not the magic bullet. It's one of our therapies that helps to swing the caries balance. Just one of our therapies. And there's always some doubt out about Fisher caries. In fact, you'll read in literature, or maybe you were taught in school, that fluoride doesn't work in fissures. Nonsense is amazing. It does as well because of access, because of diffusion. But here's a randomized trial on fluorides and sealants for Fisher caries prevention. It just came out a few days ago in Dental Research. A study by Liu et al. 101 children, average 9.1 years old in China, using a fluoride toothpaste. It's the baseline. And there were groups over and above that. Group A, sealant. B had fluoride varnish every 6 months. Group C, silver diamine fluoride. And Group D was a placebo control that had a water treatment. And bits and fish sites with dentin caries were measured at 24 months. And in the sealant group, 1.6%. Sodium fluoride varnish group, 2.4%. Silver diamine fluoride, 2.2%. And those three were not significantly different. And that's interesting in its own right.
Yeah, John, I thought that was a very interesting study. I just read it as well, and you know, we're so conditioned because we hear so much in the research, or we hear so much about, you know, fluoride varnish, sodium fluoride is not going to work in a pit and fissure in a fissure site. You know, we're conditioned to think sealant first, but so see this, you know, be really competitive with the sealant because there was no statistical difference, and the silver diamine fluoride, I thought that was interesting as well. Yeah, I thought it was an interesting paper because it certainly validates the fact that, and this was a very well done study, validates the fact that fluoride varnish will work in a fissure site.
Right, it's a landmark study in my opinion, and the control group was double the caries, and that was significantly different. I'm interested that there was that level of caries. In clinics, we see a much higher rate than that, but it's all relative within that particular population. And
yep.
And this was on a basis of regular use of an over-the-counter fluoride toothpaste as well. So sealants obviously work. That was with regular fluoride toothpaste and the sealant, or the varnish needs diamine fluoride when you look at this.
Right, exactly. I came to the same conclusion.
Yeah, the problem is, of course, if you go to high-risk caries, you have to deal with the bacteria, and that's what the diamine fluoride would also,
yep.
silver diamine fluoride would also do. But, of course, it's not available in this country yet. On to sealants in dental caries. I'm sure you're all aware, although it may have disappeared off your radar screen, that a document came out from an expert panel through the American Dental Association about the use of sealants. We've known about sealants for a long time now. We've seen data about them. We've got 10-year studies on them, and yet many, many practitioners, including pediatric dentists, still don't use sealants. So in JADA in September 2011, there were surveys that went out to general dentists and pediatric dentists, and they were asked various questions regarding sealants and non-cavitated lesions. And here's the numbers. This were 35% general practitioners and 52% pediatric dentists said that they would seal the molar without radiographic evidence of decay, which I thought was actually good to see. I'd like to see more than that, but if you can take a few minutes, although I went through pretty quickly, one of the caries risk factors that came out with very strong odds ratio was deep pits and fissures, which has been in the literature for years, but for that to be part of the whole risk is very interesting that it came out strongly. So radiographic evidence at the D1 level, the less than 4% would seal and 9% would restore. That I thought that was rather interesting in its own right. Kim, do you want to comment on that?
I find the results interesting as well. One of the issues that we have, I think, in the U.S. Is the concept of sealing over non-cavitated or graphic evidence. Basically the IC-DOS like 0, 1, and 2 type lesions. And there's such a preponderance of evidence to support that. And I think that in the U.S. tend to be a little biased against sealing over any site that looks like it may be an initial carious lesion, whether it's cavitated or not cavitated even. And I think their fear is that they've seen some of those lesions, that sealed over previously fail. I think a lot of that's related maybe to, operative technique in terms of trying to place the sealant. For me, it really just I see that as I'm out speaking and asking people, and would you seal over a tooth like this? And very few people raise their hands. So, in spite of the fact that we have so much scientific evidence to support that, and I say for myself personally, I've started sealing. I'm a lot more comfortable with using sealants over non-cavitated lesions, just based on all the scientific evidence that I've read, and it has not been an issue for me clinically. So.
The very key things is to do the risk assessment at the same time. So if you have a high-risk individual and you place a sealant over a non-cavitated lesion, there's a good chance that it will progress. So you need to risk at the same time. And I think that's the bottom line. Just placing the sealant's not going to do it. You've got to lower the bacteria and increase the fluoride and place the sealant. And bingo, you've got success.
Yep. Yeah, John, I think that's probably why I have more comfort as well now, because I am assessing the care risk of that particular individual before I make the decision, whether to seal it and certainly if it's a high-risk patient, we're talking about behavioral modification and protectors and the pathologic factors, trying to get them back in balance and seeing them more frequently. So I'm a lot more comfortable, doing some of those procedures as well.
Right. Your high-risk patients, you should be reclining probably 4 months. Is that what you do in your practice?
I actually see them every 3 months, John.
3 months, okay.
Yep.
Say 3 to 4 months. Realistically, in a dental school setting, if you can get them back 3 months, it's pretty good.
Yeah.
So anyway, moving right along. So just to wrap that one up, the US dentists surveyed have not adopted evidence-based clinical recommendations regarding sealing of non-cavitated carious lesions, and yet there's tremendous evidence out there. So, folks, here's another challenge. Assess the risk, bring the risk down, and put a sealant on over that non-cavitated lesion, and don't drill and fill it, please. The worst that happen is it turns into a deeper lesion within 12 months, and then you have to drill and fill it, maybe. Okay, moving along here. Here we go. I'm going to take a change in pace here. You may or may not recognize this as myself in my Antarctic gear, sitting in front of a fantastic mountain. The atmosphere down there is the cleanest you'll find anywhere in the world. Even high mountains that I've been in, I've never seen colors like that in the sky. And Kim, you've been there as well. Would you?
Yeah. It's just a remarkable environment.
And behind me is a fantastic tooth that does not need a restoration. Anyway, moving on to protective factors. Again, I want to deal with bacterials from extrinsic sources, and to talk about a recently published paper. It took us some years to get it out. A study was done some time ago, and it actually is true to some published work, and including what Kim has written, and I make no apology for that. These are the facts. This is the study, and then I'll go on and modify after that. The ATA had another expert panel on non-fluoride caries preventive agents, and I don't want to criticize the panel, but I'm going to. And the executive summary of evidence-based clinical recommendations was published in September 2011. And they viewed evidence from 50 randomized controlled trials and 50 non-randomized studies, talking about the efficacy of various non-fluoride caries preventive agents. And the way that the report was written was that the group was biased against any of these, and that anything other than the fluoride just wasn't worth even bothering with. And that's a shame, because we have so much evidence that you have to deal with the biofilm. So, quite realistic about it, we're going to use the best that we've got. So, okay, I'll use another part of my life. If you're in the mountains and you break your leg, in the days before helicopters, you know what you did? You made a splint with what you had, and you splinted up that leg, and you carried that person out. That wasn't the best therapy necessary, but that was what you had available. So we're kind of at that with our antibacterials right now. So said xylitol chewing gum, there was weak evidence in greater than 5-year-olds, and there was expert opinion in favor of xylitol for all ages. There's a study that came out last year that was not published yet, but was presented at IADR, that showed that xylitol was not effective in a big clinical trial in adults. However, there's a lot of evidence that it is effective, particularly in children. There was a study with chlorhexidine thymol varnish every 3 months that had some positive effects on root surface caries. There are numerous chlorhexidine studies that have showed it was not effective against caries. And I'll talk about that in a moment. But rather than leaving it at that, they came out and said chlorhexidine is therefore not recommended. Not use it. All right, there's evidence for that, and I think that was a really unfortunate statement. I could set us back, and I've been fighting with that ever since. But those trials used the regimen that I did in my clinical trial. And what we did in our clinical trial, which some years ago now and just published a couple of months ago, was we experimented with bacteria levels, and we came up with a regimen that actually did affect the bacteria. And that was published in CariFree in full just a couple of months ago. And if you want to go to that paper, it's numerous pages long. You can have a lot of fun reading all of the in-depth, and there's more to come yet. So I'm going to show you some of the key data, which some of you have seen before. It was a randomized clinical trial, and I don't have time to go into all of it. It used two things: antibacterials, which was chlorhexidine, to reduce the bacterial challenge. That was the best one we had available at the time. It used fluoride therapy, fluoride mouth rinse, to reduce remineralization. And I'll tell you right from off the bat here that if we did it again, we would use 5,000 parts per million fluoride toothpaste, which would be much more effective than 0.05% fluoride mouth rinse, which our patients didn't use, and we know that didn't use much, at least, with that from measuring fluoride in their saliva. So what did they do? Well, we started out with frank cavities, 1 to 7 cavities, all of them. They were all adults. We had 115 in the control group, which was conventional treatment. We took samples every 6 months over a 3-year period. And in our intervention group, they used chlorhexidine rinse, 0.12% chlorhexidine gluconate. And the difference was that all of the other studies that are out there have used it for, say, 2 weeks every 3 months, or variation of that. We found that if you used it once a day for 1 week every month, what it did was brought the bacterial levels down dramatically. And we did experiments towards that, and that's covered to a small extent in the paper. So, baseline activity, baseline bacterial numbers. On the right-hand axis is the logarithm of lactobacilli, and on the left-hand axis is the logarithm of mutans streptococci. On the vertical axis is the surfaces. What does all this mean? See in the back part of the graph, there are very, very high peaks, like you see in the Himalayas. And the peaks are decayed surfaces, and coincide with a combination of high lactobacilli and mutans streptococci, and I'm sure high numbers of bifidobacteria, actinomyces, etc. So baseline before they had any therapy. And if you want, you can see the same figure in the mountains of the Himalayas. So chlorhexidine, 10 milliliters daily. We want to keep it simple for a week. And where our patients complied, we did compliance measures. We called them up every month and reminded them to use their rinse. Intervening 3 weeks, they were supposed to use their fluoride mouth rinse, but that was too complicated for these people. Some of them did, most of them didn't. But they used their chlorhexidine, and that was the regimen. Can't overemphasize, repeat every month. And the data, in terms of bacterial reduction, on the vertical axis, forming units per mil of saliva logarithm, and visit every 6 months on the horizontal axis. Use the blue line at the top, that's our control group. And the first visit, from visit 1 to visit 3, was restorations were done, and you'll see there's very little fall in mutans streptococci, even they're having as many as 7 cavities filled. Restorations didn't do much for reducing the bacteria, but the chlorhexidine did. It really reduced in the line, that's our intervention group, by 1.5 log orders.
That's a logarithmic scale. That's like 150 folds, right?
Correct. Exactly. So that's a huge reduction. What we wanted was an awful log reduction, however, by 10,000 log reduction. But that ain't going to happen with chlorhexidine. Lactobacilli in the biofilm kind of laughed at us. Some patients went down and others didn't. And it was not significant. But the mutant streptococci reduction was dramatic, but it played off, as you'll see. And no one else has ever done chlorhexidine treatment longitudinally in this fashion. It was successful. Did we reduce our decay levels? 24% reduction in decay, which for high-risk individuals is actually very important. These are all people who 70% of them will normally come back with new cavities. That was our group. Within 70% of them came back with new cavities. And in our intervention group, it was 4% less than that. So that's successful, not 100% successful, but successful. What it proved, it wasn't there to prove chlorhexidine worked. It was there to show that altering the balance altered the outcome, even in high-risk individuals. If we had better antibacterial, and if we'd used a higher concentration fluoride and fluoride varnish, which we did not use specifically, I think the result would have been much more dramatic. Now I'd like to do another study, which will take another 6 years, and another $2 million to prove the point. It happened.
John, that's one of the problems that we've got. You have the AA Council on Scientific Affairs comes out and makes a blanket statement, and it takes years to challenge that with new research. I mean, it just takes, and the expense of doing those kind of clinical trials, you said it just ain't going to happen. It just takes so long to be able to accomplish that it's really unfortunate that they set us back in terms of, so this didn't work, nothing works, just stick with Sealants.
Right.
And say we should be using the best of whatever it is that we have right at the moment. We should be at least attempting to get improvement for these patients rather than just disregarding antibacterial therapy as a whole.
Exactly. And that's part of the conclusions that we come out of the study. One is that one or more cavities indicate a risk for future new cavities. We knew that, but now we've got it in a randomized clinical trial for the first time. We've got 13,000 patients over 2 years. And to high levels of mutant streptococci and lactobacilli are there when you've got large cavities. Placing restorations doesn't reduce the bacterial loading in the rest of the mouth. That's a huge factor. So you've got bacteria in the mouth. You place your restorations in 6 out of 100 surfaces. You've got 94 surfaces still left. And you need better fluoride therapy than the fluoride mouth rinse for high-risk individuals. As a result of this study, we actually moved to use the 5,000 part per million fluoride routinely in clinical treatment, and that's what you're doing, Kim, and hopefully what everybody on the call is doing. And luckily, chlorhexidine regimen did reduce the bacterial levels, but we need a better antibacterial active. Overall conclusions: targeted antibacterial and fluoride therapy based on salivary microbial and fluoride levels favorably altered the caries balance between pathological and protective caries factors and lowered the caries levels. It was altering the balance that did it. We need a remineralizing therapy, and we need to lower the bacterial challenge, and we need better antibacterial therapy. Now, I've been paid to say this, but here we go. Caries treatment rinse. And, okay, so we've got a better picture than the one I took, but that's all right. CariFree treatment rinse here, which is, I'm not paid to say this, I've got no shares in the company. This is sodium hypochlorite and sodium fluoride in separate bottles. It's mixed before use. And there's a clinical trial that I'm aware of that's been done. Hopefully will be published sometime soon. And indicates very good clinical efficacy. There's no microbiological data that I'm aware of that's published on this mix. It's chloride, of course, is bleach, and it kills bacteria, and it's a very good product. I've actually used it on a pilot basis, and it's looking good. And if we go to the clinical trial that's done by Hallett et al. In Australia, they basically indicated a 73% reduction over a 3-year period. And the cool thing about this combination is that it's antibacterial and a fluoride rinse all come together at point of contact. Kim, do you want anything?
No, John, I mean, I think that you've covered it well. The strategy in terms of being a very effective broad spectrum antimicrobial agent combined at the same time with the 5,000 or 0.05%, let's say, sodium fluoride, and having an elevated pH really gives us a chance to, modify the biofilm we're attempting to, prove with our studies. And this clinical trial had superb results. And I hope it doesn't take us 6 years to get it published. But that is the wheels of progress that turn frustratingly slow at times. And you can relate to that. But no, we were very pleased with that clinical trial, and it really mirrors what I see clinically. I've been using this for about 7 or 8 years now, in terms of its efficacy in getting, the in my practice.
Very good. So that risk assessment methods. So concluding on this new data that's out there, some of it unpublished, caries risk assessment methods are validated, but then be improved further. So we got validation. We're doing pretty well. We can tweak a little more, particularly by the addition of the bacterial measures and factoring those in better. We'll have some data on that in a year or two. Caries management based upon risk assessment will target those who need the therapy the most. That's the bottom line. We got the data now. You get those high-risk individuals and bring their care levels down dramatically. Bacteria are necessary for our and extreme risk individuals, in addition to remineralizing therapy. The simple answer is altering the balance. You got to bring the bacteria down and increase remineralization. It's as simple as that, all in one sentence. We've been saying actually for about 35 years now. Compliance is an important issue, so these rinses totally worthless unless they're complied with. And we need some better delivered therapeutic agents as well as more effective agents to combat dental caries. This is what we got, folks. We're presenting to you tonight the best therapy that's currently available. With a study Lingshan just published a couple of months ago on wipes. You'll see here the actual CariFree xylitol wipes. We used the spiffy wipes, but there's no reason to suggest that they wouldn't work exactly the same way. And it was dramatic. There were two groups. With a group of babies that were wiped with a placebo wipe with no xylitol, and the other group were wiped twice a day by their mothers, their mouths that is, with xylitol wipes over a period of a year, and there's a 7-fold difference in dental decay. So in the group with the xylitol wipes, there was only one patient of 22 that had any indication of any caries whatever. And in the control group with a placebo wipe, though it remained in the study, there were multiple, approximately 7 over and above. So it was a 7-fold difference in caries, and there was a group that dropped out that we also followed, and they stopped using their wipes entirely, and their caries was even higher, their bacterial was even higher, but the numbers are not big enough to publish and put into the paper. So in terms of infants, the use of xylitol wipes is huge, because obviously you can't use a mouth rinse in kids under 5. You can't get their bacterial levels down. We don't have anything good for that. Xylitol wipes are great. And anecdotally, both my grandchildren, what age are they? 4.5 and 1.5 are on xylitol wipes, in the 4-year-old. Very effective. There's proof, 1 out of 250 million, right?
But I think that's really important, John. A paper that was just published this month in the Caries Research as well did a 19-year follow-up on children looking at their streptococci level at, within the first, 20 weeks of life, and then looking, based on the dose of their mother, I think, as well. And the children that were healthy and had low mutant streptococci counts, 70-some% of them at 19 years later continue to have low counts in their biofilm and were decay-free. And so the ones that had high counts, went on to have all of this decay. And so it's really important that I think the sooner that we can intervene on these children, particularly infants, even in the first few weeks of life, to stop the transmission of this disease from mother to child, it's give them probably the best protection we can long term, and in terms of their own decay experience.
And the first few weeks of life, even before the teeth erupt, in fact.
Yep.
Paige Caulfield's window of infectivity was totally off the wall. 19 months to 36 months. There was a window of infectivity, ladies and gentlemen. It's called from birth to death. And, there's good evidence. Another paper just came out. This is diverting a little bit here, showing a bacterial population in the mouths of infants, yet again, strep mutans and lactobacilli before the teeth erupt.
In the first 6 months. Yeah.
And Francisco Ramos Gomez and I tried to publish a paper on that back about 1996, and the reviewers told us it was obviously nonsense, and we couldn't publish it, so we took that piece out and published the rest. So, vindicated now, but at first. Interesting. So I will just finish up with the last couple of slides here. We had a conference called the International Conference on Novel Anti-caries and Remineralizing Agents, held in Chile, in Del Mar, in January of this year. A lot of papers presented. It's actually just been published this week. Electronically, Advances in Dental Research is out. It's dated September 2012. It's still August. So, folks, this is as hot off the press as you can get. And the objectives were to explore the current state of knowledge on antibacterial and remineralizing agents, and have a forum for discussion of new and underutilized technologies, and to set a research agenda for the next decade. In other words, it was to showcase new technology that's coming down the road, a lot of exciting stuff, and I'm only going to give you two pieces of it tonight in the remaining couple of minutes that I've got. So we had biofilm management, new mineralizing agents, update on calcium phospholipeptides, slow-release technologies, nanotechnologies, probiotics, the oral microbiome, which is a huge area of research now, and I'll talk a little bit about that in a minute. Lasers and antibacterial action, some computational biology that I'll talk about, and an update on xylitol, polyols, and genomic analysis that's related to that. So here's one that I want to talk to you about very briefly, called Strategic Protein Target Analysis for Developing Drugs to Stop Dental Caries. And what Jeremy Horst is doing, and this is here at UCSF, in conjunction with people in the School of Pharmacy who develop drugs for a living. This is their living. It's computer-generated, and what you do is take all of the potential sites where you want your antibacterial to act, and you model those proteins in 3 dimensions. And then model the receptor sites on those protein surfaces to see what drugs will interact with them. And what Jeremy's done so far is to take all known about the structure of Streptococcus mutans and Lactobacilli species, and identified 15 known virulence factors, 16 proteins for which crystallographic structures are available, and 84 previously uncharacterized proteins that he's modeling. And he's identified numerous potential small molecules that will interfere with those virulence factors. Extremely exciting stuff. And okay, no problem. We can't play the video, but hopefully, can we go back?
Let me see. I may be able to grab it here and in a different way. If you want to continue, I'll work on it on my end and see if I can't get it pulled up.
It's not critical. I go forward or back at the moment for some reason. Help me, Kendall.
So just click on the slide anywhere and try to go up or down, see if it'll let you.
Okay.
Yep. There you go.
All right. Maybe. Done. Beautiful picture here. Is not showing up. Anyway, what happens if you look at the top of your screen there? Those pictures are rather small, but if you look at the pretty colors in the second row, you'll see models of proteins and the small molecules that can interact with those. That's the stage Jeremy's at right now. And from there, you can go to animal studies or human studies with those molecules to see if they're going to work. So that stage he's at right now, it's extremely exciting because you could put those small molecules into a delivery vehicle such as a paste, a slow-release tablet, a gel, or whatever. That's coming down the road in the future. And move on, because I've only got a minute left, to studies by Lingshan, and I'm involved with that as well. This is the xylitol wipe study, but an interesting thing that came out of that was that some of the phenotypes of strep mutans and strep sobrinus are transient, and some of them are permanent. And what Ling has done is she's taken many of the phenotypes from this study and she's done genomic analysis on them. And that means is you can do a gene sequence, which used to take years, and now you can get one of these done for a relatively small amount of money, and you can do 100 gene sequences in a month. So that's the kind of data that she's working with right now. And she presented this work at the ICNARA meeting. What you'll see here is peptide clusters, strep sobrinus and strep mutans. And you'll see these orange or red marks here, which are showing you actually different genes in the various isolates. Each of those columns is a clinical isolate from her clinical trial on the xylitol. And if you look here at the ones that are highlighted with these blue lines, you'll see that they actually match up with several of the isolates. If you look up to the top row, you'll see it matching up there. And then over to another, you can see some matches there also with particular series of genes. And again, as we go on down, we can highlight each of these clusters in the orange-red here, which are unique to several isolates and not to the others. Now what she's identifying is various genes that are related to virulence factors and doing some laboratory experiments to modify those virulence factors, which will end up with gene-directed antibacterial therapy. That's for the future, ladies and gentlemen, just two exciting potential antibacterial treatments that will come out of here, and also some secrets to the action of xylitol. Also out of ICNARA, some improved Fluoride, calcium and phosphate delivery methods, and I think Jeremy Host's work on the targeted computer-generated small molecules could be a fantastic step forward.
Dr. Featherstone, if you, at the top of your screen, I actually pulled in a new document. I got your picture. And so if you wanted to go back to it and just talk a little bit about it, you're more than welcome to. I mean, you should see, at the top of your screen, you should see two tabs, one that says Cariology Update, and then right next to it, it should say Presentation 1.
Ooh, oh, yes.
Yep.
I click on that.
So yeah, go ahead and click on Presentation
perfect.
1, and that should be your photo.
Okay, that's perfect. Thank you. So
no problem.
what we hear is the small molecule, that's the green one with the various benzene rings and whatever in there, docking into a receptor site on the wall of a protein from Streptococcus mutans. And that particular molecule will also interact with numerous different phenotypes and also with some of the lactobacilli as well. So that's a pretty, I think, a fantastic picture illustrating that work. So thank you very much. And I'll come back to my last slide here. I think I've hopefully left you much to reflect upon. And here you'll see me and my significant other kayaking in the Antarctic. And the trick, of course, is to maintain your balance, not fall out either way, otherwise you're dead. And it's really, what you want to do in terms of caries control. And I'd be happy to answer questions.
Balance to survive, John.
Exactly.
Yes, thank you, Dr. Featherstone and Dr. Kutsch. Also, thanks to everyone for all of your questions. We've had quite a lot of good conversation and lots of good questions coming in. So we'll get started. We'll get through as many as we can. If you have to break off the phone, if we go over time a little bit, that's not a problem at all. Like I said, you will be sent a recording of the webinar. So if you want to listen to the Q&A later on, you're more than welcome to do that. So I think all of the questions we could pretty much have both of you speak on. I think you can both bring in some good insight. And the first one, we've had actually quite a few questions just about compliance in general. I know that was something, Dr. Featherstone, that you had mentioned in one of the studies and making sure patients were compliant with the chlorhexidine that they were using. And I think typically that is an issue, especially in private practice, and I think that's where a lot of our attendees tonight are coming from. And so just addressing how you might regulate compliance or just kind of brainstorming on ways to do that in a clinical or more private practice setting as well.
Right. It applies in any practice setting, to tell you the truth, and it doesn't matter whether it's FQHC or a public setting or Head Start kids or higher socioeconomic. Compliance is an issue because we're relying on people to use these products in their home, and it relies on motivational interviewing, which is a technique which you can learn pretty easily. If you go to the November issue of the CDA Journal, and you can actually find that online, cdafoundation.org. Phil Weinstein and company out of Seattle have a very nice paper on motivational interviewing. Cut a long story short, you persuade the patient or the parent and the child patient to buy into what are they going to do to solve their problem. And you point out they have a problem, they create the problem, but they can be part of the fix of the problem. You, the practitioner, can't fix it. And talk about this of the chlorhexidine, how it tastes bad, or the caries rinse, how that tastes bad. But it's like any medicine, it's fix it. You show them their bacterial test numbers, you talk about the disease, and you can do all that in a few minutes. And I've personally done that with a lot of patients. I've worked in significant others practice doing this with parents, and light bulbs go off. And they go away and use it. And you need follow-up. You need your desk people to call them up and say, it's time for you to use your mouth rinse again, or you're using your 5,000 part per million. Do you need any more? Can I add to that?
I think you've covered it very well. Certainly, compliance is a huge issue, and it's a huge component of our behavioral change, and maybe their current behaviors I think plays a significant role in this disease, whether it's lack of home care and lack of protective features, or whether it's an abundance of pathologic factors, including maybe their diet, or maybe it's medication that is inducing the stomach that they really don't have any control over. But, if they motivational interview, I use that. I think it's wonderful. I'm also branching into wellness coaching, but you have to be able to get the patient to understand that they have a problem, identify they have a problem, and be ready to actually take ownership in doing something about it and being accountable, because they're going to have to make a behavioral change. They either have to use the products that we're giving them, so that means they're going to have to do something new, they may have to stop doing something that they're currently doing. They're a combination of both, but if they're not compliant, the best 5,000 part per million fluoride product in the world does no good if they won't use it. And if they do use it, but they continue to drink 6 big gulps of Mountain Dew a day, that's not going to make up for that. So, it takes them being able to understand and I think wanting to make a change, wanting to get healthy. And the patients that I sit down and counsel on that and get them to the point where they want to make the change, compliance has been really successful in my practice. So, and I, John, in your studies, you probably report the same thing, that when patients participate in the study, that compliance, as challenging, I think, as we may think that it is.
You have to have them buy and get on board. They don't do what their healthcare provider says. They'll do what they want to do, understanding what to do.
Hey, John, I that's a really good point, and I'm just sitting here thinking, it's like when we go through the risk assessment process, suddenly for the first time they have an understanding of the disease and maybe what behaviors or risk factors and predictive factors there are that are playing a role in their balance. Suddenly they can take ownership in that. When we tell them to floss, tell them to brush more, they're going to do what we tell them to do. They're going to do things that they feel, and if they feel like they have a strong motivation to go ahead and try and get healthy and stop having cavities or get out of pain or whatever it is for them, or stop the embarrassment of the appearance of their teeth or the expense of the dental issues, motivating factors help them, but they need to understand the disease and take ownership of it. And really, John, your risk assessment form really, by the time we go through that process with a patient, most of them ask, what can I do?
Right, and that's the key to it. Just think we all know that smoking causes lung cancer and we're going to die of lung cancer. Do we do anything about it? Do we stop? It requires some motivation to do that. It requires, holy cow, my uncle died of lung cancer last week and I'm going to stop smoking. That's a bit extreme, but the same thing applies. So, but it's a huge issue, and we could go on for hours, but I think we should move on to another.
Right.
Yes, absolutely. Thank you. And the next question, so Dr. John Quace recommends the CTX-4L and 4-INS for perio disease and maintenance also. Are there studies that back this up better than chlorhexidine?
Kim, do you respond to that?
Yes. Answer to that is no. There are no clinical studies. It's all anecdotal. It's off-label use. At manufacturer, we haven't gone through. While I personally believe it's an antimicrobial agent for a broad spectrum of bacteria than say maybe chlorhexidine is. We don't have FDA clearance to market it for that use. So practitioners are using it that way off-label. Dr. Quace recommends it that way, obviously based on clinical success they've had with it. But from a standpoint as a manufacturer, that's a process. We've been focused on dental caries, and we'll continue to be focused on dental caries, but that is one of the things on our radar that we'd like to address, is to go ahead and seek approval for that.
And we hasten to add that the use of fluoride varnish, 5,000 part per million fluoride, and chlorhexidine and hypochlorite are all off-label uses for caries.
Correct.
But they work. There we go.
So, go ahead.
Go ahead. No, I'm done.
Okay. So the last question that I think we'll take tonight, and we have a lot more to answer through the remainder of the week. What are the primary products and agents used for remineralization? Currently
out there on the market? Okay. It's very simple. In terms of remineralization enhancement, I say advisedly, we can't have remineralization without calcium and phosphate. So if you have salivary dysfunction, you have to add calcium and phosphate. So with that proviso, you have normal salivary flow, you have sufficient calcium and phosphate. Then add fluoride, and that one of those items is fluoride in the drinking water, enhances remineralization. Next step up is fluoride in toothpaste over the counter, which works in a lot of the population, and that's made the huge change in caries in the 70s and 80s that occurred in 12 Western world countries. Then you go one step up further, which is the 0.05% or 0.02% sodium fluoride or standard fluoride mouth rinses, which are better than the toothpaste because you don't actually wash them out with water. That's an enhancement as well of remineralization. Then we go to the 5,000 part per million toothpaste. And speaking of compliance, by the way, people switch to that with ease. They're used to using a toothpaste. They're used to complying with a toothpaste. If you persuade them to use that 2 or 3 times a day, it will make a huge difference right there. Then, of course, we have fluoride in other forms, such as fluoride in a gel that you apply in your office with high concentration, up to 12,500 parts per million, enhances remineralization for weeks. And fluoride varnish, of course, which is probably the most convenient and becoming the most commonly used remineralizing agent in terms of what you put on in your operatory, in your clinic. The compliance and over-the-counter use and take-home 5,000 part per million, or remineralization, plus the calcium phosphate products that are out there. So you've got Reclent and you've got MI Paste Plus, all adding calcium and phosphate, particularly for extreme risk patients or high risk patients with low salivary function. I think I've covered the waterfront. There's the stannous fluoride, of course, another fluoride delivery mechanism, but those are the key remineralizing and enhancing agents.
Yeah, certainly the greatest abundance of remineralization research has been done with fluoride, and fluoride certainly works, and I think has to be a key ingredient in our remineralization type therapy. We know that the action of fluoride increases the degree of crystallinity of the enamel, and then the calcium phosphate products. Now we're using nanoparticle hydroxyapatite, but there are a number of different forms of calcium and phosphate available in different products. But the calcium and phosphate, it actually is deposited as a new layer of hydroxyapatite mineral on the tooth. So the remineralization studies with any of the calcium phosphate products, there haven't been a large number of clinical trials yet. I think there's a lot of work to be done there, but certainly the early results on products are very promising. So
risk patients.
Yeah, and particularly in the high risk patients. I mean, that we really need to put in the studies are the ones that need the therapy. So many studies are done on healthy individuals and show really good results, but we need to demonstrate the results on the high risk or the extreme risk. And John, you brought up one other really good point on the compliance. I think one of the reasons that the 5,000 part per million gel, like work so well, is that if you can get them just to substitute, they're already using a dentifrice, just put this in their hand, they're already doing something. If you can just substitute a product into a behavior they've already got, that makes compliance a much easier issue for all those patients, rather than adding some new procedure they have to do every day. Or I've seen recommendations that, listen to a speaker and they have a list of about 18 things they want the patient to do each day, and I'm thinking, I wouldn't do that. I mean, it's just not going to happen. So the simpler that we can make it for the practices and the simpler that we can make it for the patients, the more success we're going to have.
Right, and one thing that I mentioned before that I recommend to everybody that's out there in private practice, which is most of you who are still on the line, is to dispense these products or sell these products out of your practice. And that, I know, almost like sacrilege. I should be burnt on the stake for saying that, but it's what you should do, because the literature tells us if you write a prescription, some 30% or so of those people don't make it to the pharmacy. And of that do, 30% of those don't use the product anyway. So that's half your people right there. So if you've got your 5,000 part per million, your Apatite toothpaste, or your mouth rinse, or your chlorhexidine right there in the practice, you can sell it, dispense ring-fence it, build it into your costs, do it whatever way you want. And the best way, from a motivational point of view that I've heard of from several of my friends, is they're actually selling it to their patients at cost, inviting them to go to the pharmacy and pay twice as much for it. And that actually motivates them to say, wow, this is something I can get from the pharmacy, but I can get it from you for half price. Wow, this is cool. That's another motivational tool.
Yeah, I'd agree with you on that as well, John. A lot of our profession is reluctant to dispense products or sell products in their practice, but my experience with this in the last 12, 13 years, I can put the product in the patient's hands when I have them motivated, sitting there. I have a much better opportunity to have compliance and success with them than I hand them a note or prescription and say, here, go do this. Again, it just doesn't work as well. We know that. So.
Well, you know why we started doing it here in our clinics? That's because I had animals, and I used to go to the vet, and every time I took the dog to the vet, she would prescribe the product and dispense it right there. And I took it home. I took the dog home. I took the product home, and
right.
Did it right there. Holy cow! If the vet can do it, so can we do it in the dental school.
Yep, absolutely.
Excellent. Well, thank you for your great answers. So I would like to just share a couple of items with you guys quickly before we wrap up here. First, we would really like to introduce, and we are excited to introduce to you, a new book called Balance, written and published by Dr. Kutsch. It is a great summary of what Dr. Kutsch has been working on his entire career and how he has successfully implemented CAMBRA in his private practice and all of the wisdom that he has taken from his mentors, Dr. Featherstone here tonight included. So for anyone looking to just learn about how this lives and breathes in an office day to day, or if you're just looking for more information on the CAMBRA topic, please give us a call to pre-order a free book. You just reference the discount code at the bottom of your screen for being on the webinar tonight, and we would be happy to send you a copy. And last but not least here, for those folks who are ready to get started, you've heard something that has sparked your interest tonight and are excited to get going. We're offering a discounted package for those participating in the webinar, which you can see on the screen. This is just a great introductory package for practices just getting started, just getting introduced to the idea of CAMBRA and what that may look like in your practice. So again, if that's something that you are interested in, please give us a call. Our phone number is there at the bottom of the screen. Just reference, again, the discount code will get you all set up. It does include training and that sort of thing. So Dr. Kutsch or Dr. Featherstone, did you have anything else to add before we break for the evening?
You know what we should be doing? This is our future of the standard of care. The patients love it, really works. And don't be afraid to get started tomorrow.
Yeah, and John, I would agree, and I just want to thank you so much for a very informative. I always enjoy your insight into the research, and thank you so much for all that you do in terms of the research. These trials that you do, you validated so many things in those last two papers that you published that took years of your life and your work to make that accomplished. But thank you so much for that, and thank you for a great webinar tonight. I think everybody thoroughly, I know I enjoyed it, and I'm sure everybody else did as well. So, John, we'll be in touch, and say hi to everybody for me tomorrow at the CAMBRA meeting. I apologize for me, but we'll together again.
Yep, you're very welcome. Thanks so much. Okay.
Thank you,
everybody.
Bye now.